Welcome and good morning. My name is Kathleen Creason. I'm Executive Director in my daytime job of the Osteopathic Physicians and Surgeons of California, and I also serve as a board member for the Neuropathy Action Foundation. It is my pleasure to serve as your MC for today. I'll be introducing speakers. But before we get started, I wanted to just welcome you to the 10th Annual Neuropathy Action Awareness Day. And, you know, that's a pretty exciting step. Yes, worth a round of applause. Thank you. Dominic Spadafora started this organization 10 years ago today and has done a tremendous job of just bringing everybody together, raising awareness of the issue, and he's done a terrific job. He's such a tremendous patient advocate. If you know Dominic, he loves to stand behind the scenes and have everybody else get the attention and the awareness, but without him, this would not happen. Dominic, stand up and say hi. So not only wanted to welcome the hundreds of folks that are here in the room today, wanted to recognize and acknowledge the more than 1,000 people who are watching online. So we've got a tremendous international audience of folks viewing online. So welcome. I hope everybody, both here in the room and online, enjoys the wonderful program that we have planned. Wanted to also, for the folks in the room, make sure that we recognize the sponsors and the exhibitors that are here. Without them, we truly couldn't have such a tremendous and successful program. So thank you to the sponsors and exhibitors. You'll see them, a list of the organizations that have supported the event in the program, and I know that's available to the folks watching online as well. It's on the NAF website. So for those folks who are here, I encourage you to interact with the exhibitors. They've got a lot of great information, so please take the opportunity to do that. And just a couple of housekeeping items. We will have lunch today here in the room. We will ask that you actually leave the tables so that the staff here at the hotel can get the program, the lunch set up. So we'll let you know when you need to do that. We've also got a silent auction that's set up in the back of the room. Encourage you to take a look back there at some of the wonderful prizes that are available. Bid high, bid often. That event will close at 3 o'clock sharp today. So take advantage when you have the opportunity during the breaks or luncheon or just before 3 o'clock to write your number and name down there. We did have a little bit of a change in the program. The first speaker unfortunately canceled, but we are very fortunate to have had Dr. Jonathan KATZ step up and agree to serve in that person's place and give the presentation. So it is my honor to go ahead and get the program started by introducing Dr. Jonathan KATZ, MD. He's a Chief of Neuromuscular Services at California Pacific Medical Center. And incidentally, I'm not going to read his entire bio because we would be here all day if I did. But just to hit some highlights, he was previously with Stanford University as an Associate Professor of Neurology. He's an expert in EMG and clinical diagnosis, and he runs one of the busiest neuropathy clinics in the San Francisco Bay Area. Dr. KATZ.
Got to hold this. Can't. So actually, it's the other talk first. Wrong talk. So one of my favorite things in the world to do, sarcastically, is to give somebody else's talk. But the person who's supposed to give the first talk is named Todd Levine. He's a good friend of mine, and we were planning a trip to Cuba, the two of us, and because we got invited to do an actual neuropathy program in Cuba, and it was all exciting and everything, and a couple more people got involved, and before you knew it, everybody had invited their wives, and mine wouldn't go, so that made me available, and I don't smoke cigars anyway, so we're good. And I'm happy to be here. And before I start, I want to thank Dominic. Really, the guy's a great guy, and I've known him since before this started, and we're all really lucky to have him. Neuropathy is like a really hard field, and I'm going to give two talks. The first one is Todd's talk. I have a problem when I give somebody else's talk, which is sometimes I don't agree with what the slides say, and I have trouble keeping it in. So forgive me if like halfway through I completely disagree with something it says on a slide. Because neurology is a lot of opinion, you know. It's not really like you might expect, like we have easy answers to everything, because we don't. I mean, one of the participants here, it came up to me 15 minutes ago and asked me about a patient I have in San Francisco who has a neuropathy that's somewhat difficult to treat. And the question is, should he be treated with this? Should he be treated with that? And the truth of the matter is we don't have good answers to a lot of these questions. A lot of it is a lot of give and take. Doctors have really different opinions from each other. So what I say and what Todd says or anybody else might be really different. There's also, I suspect many of you in this audience have neuropathy. There's also some difficulty. It's not the easiest diagnostic field. It seems really easy, but sometimes it's really not, and there's a lot to it. So the second talk I'm going to give is going to go into a lot of not just the diagnosis, but maybe some practical ways doctors think, so you have a good understanding of what some of the issues are. But this talk is more about treating the symptoms and kind of getting down into the core of what people experience and how hopefully we can make them feel better. So I'll do my best, and I think there'll be time at the end to ask questions if anybody has any. But let's start off just with a little overview of the peripheral nervous system. The peripheral nervous system is the part of, and then stop me, like everybody can just put their hand up right now if you completely know this already, but we'll start with some basics. The peripheral nervous system is the part of the nervous system that pretty much goes between the spine and your muscles and your skin. So it's taking signals back from your skin and your joints, telling about sensation, telling about the position of your joints, and it's also sending signals out from the spinal cord to the muscles, which obviously makes muscles contract and makes them strong and makes them full. When those nerves aren't there, things like atrophy develop, weakness, so on and so forth. And the third type of nerve fiber is the autonomic fiber, which gives us information about like saliva in our mouths, our blood pressure, our veins, our GI tract, and that kind of thing. So pretty multifaceted system. When these things start to go wrong, so when the peripheral nervous system gets sick, it follows that the problems that you have are you lose sensation. That's from the sensory fibers not working. Sometimes fibers don't just like 100% disappear and stop working. Sometimes they just work weird. So when they work weird, a sensory fiber, it starts sending fuzzy little signals back to your brain, and your brain interprets those fuzzy signals as things like burning, stabbing, tingling, shooting pains. That's why peripheral neuropathies can be painful. Obviously, weakness is another symptom when the motor fibers don't work. And those little fibers, those nerve fibers that I told you about earlier, that tell you about the position in your joints, when those go, you start getting balance difficulties. So that's the reason that peripheral neuropathy causes these specific symptoms. And jumping right into it, so Todd thinks the best place to go after the last slide is treatment, and we'll just talk about it. So pain is one of the most common symptoms of peripheral neuropathy. And a big dose of treating peripheral neuropathy, to use a pun, is to figure out how to treat the pain. And there's tons of different pain medicines, and there's no right way to do it. And if somebody comes into my office and they say, Doc, I got burning in my feet or whatever, the diagnostic part's going to be pretty easy. It's not going to be a giant workup. It's not going to be confusing. But the treatment part is something that we'll probably engage in a relationship for a long time, trying to figure out. These medicines generally don't make your pain disappear, right? And I'm sure there's a lot of you out there who've experienced the goal of these medicines is just to make the pain less. And we say, like, for any given medicine, probably 50 to 70% of patients will get a 30% improvement on their symptoms, and about 30% of patients will get a 50 to 70% improvement on their symptoms. So we're not looking for miracles, but usually we're looking for management and making people's quality of life better. So the main medicines that we use fall into different categories. So anticonvulsants or seizure medicines, as you can imagine, reduce electrical signals in nerves. They just kind of make them fire a little less avidly, so there's not so much signal going back into the brain. That's why they work for seizure medicines. They kind of slow down electrical impulses so you don't discharge your whole brain and start to convulse. But that's where those medicines come from, and gabapentin is kind of the main one to use these days. But people sometimes don't like to use gabapentin because it's 3 times a day, and there's a similar medicine called Lyrica, and people like to use that medicine maybe a little bit more, but insurance companies don't like you to use it so much. So one of those two, but they're very similar medicines, but those are the drugs of the day. The other category of medicines that get used are antidepressants. So the antidepressants, like one of the common ones used these days is Cymbalta. There's also amitriptyline, which is also called Elavil, and nortriptyline, which is another one in the antidepressant category. And these work not so much by reducing electrical potentials, but they tend to change the type of transmitters in your brain, so maybe you don't pay as much attention to pain, which is kind of like a parallel to depression, because in a sense, depression is a kind of pain. It's just more emotional pain, but your body's able to adjust itself through transmitters so you don't feel pain. And then the last category here is pain medicines, which I think is a pretty broad category, but he's probably talking a little bit here about opiates, Norco and that sort of thing, Tramadol, Vicodin. And I think as a general rule, those medicines are a pretty good group of medicines to stay away from unless it's a very last resort, because they tend to be addictive. And there's a bunch of other medicines I won't go into that fit in the middle that are also in the category of different seizure medicines and other anticonvulsants. And then nutritional supplements, I'm not a big fan of. I don't think there's a lot of evidence basis for any nutritional supplement really being helpful. But I think where nutritional supplements can be helpful is I really believe that in the treatment of neuropathy and any pain, not just neuropathy pain, but any pain disorder at all, it makes a lot of sense to have choices out there that are kind of in the placebo effect category. Because I think people who want to help themselves will in fact help themselves. So I don't see any problem, and I say this to all my patients, with going out there and trying something because you think it might be helpful, because just that act in itself might be helpful. And when I say there's no evidence basis to something, there's nobody who's ever done a study of, like, name some nutritional supplement, a vitamin or whatever, and proven that it's effective in treating neuropathy. And I think a lot of these things get in there like, hey, take some B12. Well, why would you take B12 if you don't have a problem with your B12 level? Well, maybe it just makes people feel better. And heck, if you have a pain problem and something's making you feel better, why would anybody possibly argue with that? I think medicine in general needs these sorts of treatments as part of the armamentarium to make people feel better in a lot of different ways. So that's what nutritional supplements are about. Infrared light therapy is kind of a concept similar to what I just said. Electrical stimulation, sort of the same sort of thing, and magnetic stimulation. I think all these things kind of fit into the category of if you make the effort, you might feel a lot better. So here's some other things, like how do you treat these symptoms? Well, diabetic neuropathy is kind of the classic breakdown of this, but you lose sensation in your feet, and there's a risk there always of something terrible happening because you're rubbing your feet, you get an infection, it's low grade, you don't feel it, you don't treat it. Before you know it, you have a horrible ulcer because you're continuing to kind of irritate feet that have bad sensation, and before you know it, you get an ulcer. So common theme, imperative to protect your feet, look at your feet, pay attention to what shoes you're wearing, pay attention to how you put your socks on, so on and so forth. Real important. More than 40,000 amputations per year are related to neuropathy. Clean your feet, cut your toenails, inspect your feet, like I said, have a podiatrist see you. Now, I think in general, for my practice, they don't refer us to diabetics anymore. We're not, I think the diabetic doctors kind of figured out how to treat diabetic neuropathy themselves. I have rarely seen a case in the last few years that has such severe neuropathy that we have to worry about this. But we'll talk about it once or twice, and that's good enough. Now, this slide is one of the slides that I'm not entirely 100% positive what he was thinking about. There was no phones to Cuba last night, so it was a little hard to say, but he's talking about walking versus resting. Many other things cause leg pain. So I think the point here is your feet hurt, and it's a common symptom of diabetic neuropathy. So obviously, you are if you have a painful foot situation, you're in a management mode all the time. So if walking hurts your feet, don't fight it. Your feet are trying to tell you it's hard to walk. Put your feet up, rest, pay attention to it. I think the lesson here is just take care of yourself. So a lot of people I see with painful feet who are like school teachers and they're on their feet all day. It happens to be like June right now, so probably 9 times in the last 3 weeks of my practice, somebody said to me the words like, "Thank God the school year is over because I'm not on my feet all day." But this is the kind of year you hear it, so that's why that's fairly salient to me right now. But it's, manage your symptoms. Like, don't be afraid to listen to your body and take it easy. I think that's one of the biggest mistakes people make with treating their symptoms is not like listening to themselves and you think, I got to get this done, I got to get this job done, we're all puritanical Americans, we got to do this, we got to do that. It's very hard to say to somebody, just try to take it easy and slow down. There's other things you could do while you're in a seated position or while you have your legs up. Other things can actually cause leg pain, so radiculopathy and stenosis. I mean, a lot of people who come in with peripheral nerve problems in my practice actually turn out to have root problems in their back, and I'll get into that in the next talk. So if you're getting pain shooting down your legs from your back and your feet are numb, it might be a root problem. If you're getting a lot of cramping in your legs from walking and moving around, it's another symptom that you could get if your back's part of the problem. One of the clues to back problems is it's not the same in both feet. The left might be different than the right. There's also vascular claudication, which means your blood vessels are a problem. A lot of people get that mixed up as well, and that's another symptom where if you start walking a lot, you might get cramping in your calves. The real neuropathy cases their feet just hurt more when they walk, so they're really very different symptoms. And other things that can mask neuropathy are like restless leg syndrome. That is a common one that comes in, and the clue there is I can't sit, I can't lie down, I feel like I got to keep getting up and walking. People with neuropathy have a higher incidence of restless leg syndrome, but much more restless leg syndrome doesn't have neuropathy. But it's really not uncommon in the practice for somebody to come in with leg problems and their doctor's diagnosed neuropathy, and it turns out to be restless leg. And periodic limb movements of sleep is just a problem that your legs move a lot when you sleep. I think that's somewhat unrelated. Sexual symptoms, something that we almost never talk about in my practice. I don't know why, but it is what it is. But obviously, autonomic function is controlling sexual function. So if you have a problem with autonomic nerves, it follows that these sorts of symptoms would ensue. So don't be afraid to talk about that with your doctors. Most of your doctors probably won't bring it up unless you bring it to them. Every once in a while, a patient does come in and say, "Doc, I want to talk about this aspect of my life," and obviously we do our best to help them. Don't be surprised if a doctor doesn't bring it up, and if you do bring up that you have neuropathy and these symptoms, I'm sure it's not very hard to have a discussion about it. Bladder symptoms. So Todd says here urinary incontinence is not a common problem. It is, I don't think it's the most common problem of neuropathy. Todd has a bigger focus on autonomic neuropathy, I do. So if your autonomic nervous system is involved, and we'll get into a little of this in the next talk as well, but the autonomic nervous system does control bladder and bowel symptoms. The other thing is a lot of the pain meds can affect the autonomic nervous system as well. So again, these are symptoms that if you have them, a nerve doctor probably is not going to bring them up, but if you brought them up, the doctor would probably want to look closely at your medicines and talk to you a little bit. The people who present with like numb feet type of neuropathy, this should not be a major symptom, and it's only in the autonomic neuropathies where you would see it. And without getting into the details of how these things are diagnosed yet, I just think it's worth saying, like, bring this up with your doctor if you really need to talk about it. And it's the same thing with gastrointestinal symptoms, because again, the autonomic nervous system controls your gut. So if the autonomic nervous system isn't working, one might expect things like constipation, one might expect sometimes pain and that sort of thing, nausea after eating. You do see this like in the most, and same with bladder symptoms, like in really, the people with diabetes who present with numb feet, when it gets really severe, you'll see some of this. There are some neuropathies, like I said earlier, that present with autonomic involvement as like a first symptom. But for the most part, again, bring it up, think about it. It's important if you have symptoms like constipation or a lot of odd GI symptoms as part of a neuropathy. And there's meds that can treat this that speed up motility. You can change the way you eat meals and that kind of thing. So that's that. And cardiac symptoms are another autonomic symptom that can show up with neuropathy. And these are things like lightheadedness when you stand up, and syncope and fatigue and palpitations. I will just say here that this stuff is harder than meets the eye, again, because like think of the demographic that tends to get neuropathy, right? It tends to be people that are like over age 65, 70, that kind of thing, which is also a lot of the time that a lot of these symptoms like constipation, some incontinence show up anyway. So it can be really hard to differentiate whether these are part of your neuropathy. But if they show up again, talk to your doctor about it and understand that there's this autonomic control in neuropathy that can cause some of these odd symptoms. He gets into here this concept of autonomic testing, and that takes a very specific type of doctor and some very specific type of testing. I think I've never sent one patient for autonomic testing in 20 years of practice so far, because usually these symptoms are fairly salient, like, hey doc, I'm getting dizzy when I stand up. Hey doc, I have constipation. They're not really hard things to talk about and find out. And sometimes diagnostic testing is a little more than is necessary to really sort out what somebody's experiencing. But if you do have full-on autonomic symptoms where you're getting dizzy every time you stand up, and it's a big problem and you're almost fainting, then we've got a serious discussion where we have to have, like, does anybody here have any symptoms like a full-on autonomic neuropathy? So yeah, we got a small number, but it's a real number, and that's about what I would have expected. And has anybody ever had to have autonomic testing at a full-on lab here? So yeah, about half of the people. That is about 2 people in the entire audience. So it's about, again, what I would expect. And these are things like, again, the comorbid problems you have to think about. Like if you're getting dizzy when you stand up, you're not going to go to your neuropathy doctor and just talk about like your nerves degenerating. You have to talk about what blood pressure medicines you're on. Can we get off some of those blood pressure medicines? What am I eating? Do I have to have more salt in my diet so my blood pressure stays high? Head of the bed elevated, compression stockings so the blood doesn't pool in your feet, and sometimes drugs to increase blood pressure. Now, swallowing problems. Does anybody here have swallowing problems? We got 3 people with swallowing problems. Swallowing problems are, again, they're another super hard concept if you're sitting like in my chair in a doctor's office, because let's do a little experiment in the audience right now, all right? Just a little fun. Who has swallowing problems here? Just raise your hand for a second. So we got like 3 people, okay? Now, everybody in the audience right now, I want you to think about swallowing and swallow 3 times to yourself. Okay? Okay. Are we done yet? Are we able to? So how many of you felt that was a little hard to do? Like almost everybody in the audience, right. So the problem with swallowing problems is that once you think about it, you're going to have a swallowing problem like 3/4 of the time. And there's a word for it. It's called globus hystericus. And I hate the word hystericus because it obviously implies hysterical. And that's like moving into the politically correct group of words we're not allowed to say anymore. But globus we can still say, and it's the Greek word for swallowing. So it really implies that when you think about swallowing, you can worry about it. So as soon as I list the symptoms of neuropathy and include swallowing as one of them, what's going to start to happen to everybody? You're going to all have a swallowing problem. So then you go back to the internet and you read it, and before you know it, it's a swallowing problem. It is really not a very common symptom of neuropathy. And I fear if I talk any longer about this slide, I'm going to cause a giant problem in this group. So we're going to move on to the next slide. And this is just to prove the point here, which is the cause is dysphagia is the word for swallowing difficulty. It's spelled here S-Y, but it's Y-S technically. And, look at the causes of it. Fortunately, neuropathy is not really on this list. Neuromuscular disease is on the list. It's about 5th down. But it's the diseases like myasthenia gravis and ALS that can cause swallowing difficulty. For this group, it really should not be a giant issue. And if anybody has it, I'd be interested to hear more about it. And then I think this is like an enormous thing here, emotional side effects. Like the more I practice, the more I've become somewhat sensitive to people's issues with, and not just the more I practice, the more I age and have to deal with life, I start seeing like, hey, it's not really that easy. So you throw a neuropathy on there, or you throw any kind of painful syndrome in there, and it really can be taxing to live with that in addition to everything else. So, depression and anxiety is not an uncommon symptom of neuropathy, and it's important to recognize this. So as many as 30 people with chronic peripheral neuropathy develop depression, which is a really high number. Lou Gehrig's disease, which is another disease I treat a lot, that people actually die from, the depression numbers are actually much less. It's only 10%. So it tells you that living with chronic pain is a real problem for a lot of people. And there's a lot of treatment options with that. It's one of the reasons, like if you look down to the third bullet there, medication, sometimes those antidepressants can be a really good choice for pain medicine because they can also treat depression. And then cognitive behavioral therapy applies to really just how you go about your life and deal with pain. How do you work around it? What sort of things can you do not to think about it? And exercise has turned out to be really good for everything, in case you haven't heard that in the news. So sleep dysfunction is another common symptom. How many sleep dysfunction in here? So yeah, we're getting into a little bit bigger numbers here. Sleep dysfunction can come from a lot of different reasons. And so restless leg syndrome occurs, so you can't lie there without your legs bothering you. Pain, commonly for Lord knows what reason, shows up at night. It's a common time that pain shows up where you kind of can make it through the day. It's probably got something to do with like your mind is not like paying attention to it while you got other things to deal with, like your life. But then when you get into bed and everything's quiet, like all this stuff just opens up and you realize, wow, I'm in a lot of pain. It's really common for people to tell me like right when they're walking out of work or right when they first get in their car to drive home is when the pain really hits, or right when they get into bed. And these are all times where everything kind of calms down, so your body finally has to listen to what your body's been telling it the whole day, but you haven't been paying attention to it. So it is important a little bit to pay attention, take breaks, not like let everything build up the whole time. Or it'll haunt you when you get into bed, or it'll haunt you when you're driving home from work. There's also disrupted sleep architecture. I'll throw in there that your pain meds, like a lot of the pain meds affect your sleep architecture, so it can make it hard to sleep. And then sometimes people have completely unrelated causes of sleep difficulty. And medications have side effects, so it's another thing to think about kind of in the toad ahead of treating neuropathy. So we do have to talk about that from time to time, like, all right, what about the side effects of your medicine? Like antidepressants can sometimes go too far, make it hard to sleep. They can cause nausea. They can slow you down. They can make it hard to think. Anticonvulsants, a lot of times can cause some dizziness. They could affect your weight. They can also slow you down and make it hard to think. Neurontin and Lyrica can cause edema in the lower extremities. So these are all things that can go on top of neuropathy. And opiates, which are really difficult, I think, to manage, obviously have addiction intolerance and can cause a bunch of GI symptoms, thought, thinking problems, and a lot of emotional side effects. You can get into a lot of trouble with these medicines if you're not careful. So the conclusion is not every symptom is always related to your neuropathy. It's a really good point. Like these conditions, not just neuropathy, but like a lot of the conditions I take care of, it's hard to know like which part of it's the disorder and which part of it is something else in your life. So it's important, I think, when you go see a doctor, not just to focus on the disease. Like to a patient, especially if you have a very mild case of something, because you're kind of, if you think about it, if you have a very mild neuropathy, you're kind of a rookie when it comes to understanding neuropathy, because if you have got like a full-blown case, you kind of get a really good sense like this thing's everywhere in my life and I know exactly what I'm dealing with. But if you have like a really mild case, it's really hard to know what's the neuropathy and what's not, how much should you give attention to the neuropathy versus other things. So I think it's really important when you're talking to your doctor or you're on the internet these days and talking, it's important to be open that every aspect of your life is not the neuropathy, that sometimes it's other things. We can generally do a really good job of managing individual symptoms once we talk about it. Diagnosis is like to me, it's a gigantic theme in neuropathy in general. Like it's important to get things right, I think. I think it's also important, it's not really here, to be hopeful. Like most neuropathies, they don't change that much over time. So in addition to like dealing with all the symptoms, there's a lot of sense that your life's going to stay in control. Like I can't tell you how many patients like are sitting across the table from me with neuropathy or across the the bedside and they say you're talking to them and you throw in there like 3/4 of the way through the appointment, you're going to be fine 10 years from now. Like, these neuropathies don't change that much over time. And you kind of see the body language change a little bit. It's very relaxing to hear that these things can be managed and tend not to get worse too badly as time goes by. Now, there are exceptions, obviously, and I'm sure I'll hear something about it when we open up for questions. And many can be managed without additional medications and therefore without additional side effects. So yeah, just using common sense, paying attention to your day-to-day life can be really helpful. I'm going to stop there, and I think I got about 5 or 7 minutes for questions. Does anybody have a question before? Everybody's got a question, raise your hand. Okay, good. We'll have time. Okay. Do you want to start here?
I know these aren't your slides, and you're going to talk about more treatment options later. But why wasn't IVIG included on this?
Okay, you're very, very prescient. Because yes, I'm going to talk more about IVIG in the next talk. So we didn't want to do it twice, but you're also smart because I didn't take it out of this talk because it wasn't there in the first place. But yeah, IVIG is a gigantic part of neuropathy, but it's for the immune neuropathies, which are just one part of neuropathy. And I think Todd was focusing more in this talk on kind of the idiopathic neuropathies. Now, let me just say, like, at a support group for neuropathy, you're going to get 2 giant themes. Really, let's say 2 giant themes and 1 medium-sized theme. On the one hand, you got the subset of patients who have basically what I call length-dependent neuropathy. It's what a lot of neurologists call. Length-dependent is the word for the longest nerves are the one that have the problem. And the longest nerves are the ones that control your feet. So theme number 1 is that the most common neuropathies make your feet burn or your feet go numb. And I'm sure that resonates to a lot of you in the audience. So that's length-dependent. The longest nerves are the ones that are affected. On the other hand, you have the second theme is the autoimmune neuropathies. The autoimmune neuropathies are your multifocal motor neuropathy, CIDP, MADSAM, DADS neuropathy. Those, IVIG, the autoimmune medicines, prednisone, IVIG, rituximab, those are the big themes. So those are less symptomatic therapies. We're not going to be talking in those about how your feet burn or how you're dealing with feet. We're going to be talking more about, is your diagnosis right? Is IVIG going to help? And so it would be good, I mean, for future years, you have like a split-off session. The autoimmune people go one way. The length-dependent neuropathy people go the other way. There's a little overlap between those two, so you could have a very small third room. And then the third big theme for neuropathy is just the weird other stuff, which is like the autonomic neuropathies, the B12 deficiencies, the chemo-induced neuropathy. So there's a kind of idiopathic, autoimmune, and everything else. Do you want to do just a quick, how many of you does the first theme resonate, just out of curiosity? Just the burning feet, numb feet. So it's like a sun. And how many of you is it the autoimmune? And how many of you is the other weird stuff category? So it's about right. That was a good call. And how many of you don't have neuropathy? You're just here. Okay. Got it. How many of you are not interested whatsoever in neuropathy and came in the wrong room? None. Okay. All right, next question.
It's the only time where your feet will get pain, will hurt more when you're not doing something, where actually when you're walking, it would hurt less, which is why a lot of people, that's why exercise helps so much. Or when you said people get in their car after work, because they're not moving, people get in bed at one thing, because they're not moving, and it actually hurts more. And it does with me, so it may just be the talk later, there's a lot of small fiber neuropathy, we just talked about that, but that's probably what people refer to there. I just thought I'd play that.
That's really helpful. So two things come. So what you said, I'll just tell the audience, is a big hint that you're dealing with neuropathy is that the pain is worse like when things are quiet, like when you're lying in bed or in a car. And I think it's a good theme, like that Todd was bringing up, and I'm glad you reminded me, which is, like, you do have to use your common sense, right? Like, it's not hard for anybody, without a doctor even, to figure out, like, does walking make you feel better? Does riding a bike make you feel better? Does swimming make you feel better? Does resting make you feel better? Does putting your legs up make you feel better? Does taking a bath make you feel better? Does putting ice on your feet make you feel better? Like, these are things that you should just go through and know, because if you're going to have a condition for a long time, it makes a lot of sense to know what helps and what's not. And that gets into the concept of just, like, management. And that's something that's a theme that people should be paying attention to in the long run. The only thing I would slightly disagree with Todd on is any pain is worse when things get quiet. It's just the way the gating mechanisms work. So any pain, whether it's your tooth or, you know, a bone injury or anything, you know, when you're talking to someone, it's just the way your brain works. And it's kind of like you don't want to always worry. You know, thank God we have mechanisms that you're not always paying attention to one thing, or you'd be called autistic. So you got to be careful with the conclusions a little bit. Yeah, last question.
So you run a neuropathy clinic up in the Bay Area.
I do.
Is there anything similar down here, or?
Oh, so the question is there anything similar down here? You have some of the best neuropathy doctors in the country these days in LA. I mean, I won't give any names. You could ask me off because I'm afraid if I say somebody and not somebody else. But you'll hear from, I think, both of them today. I think they're both here later. And there's a lot of other good ones too. So there's really, really good doctors throughout Los Angeles. Now the problem with Los Angeles is not that there's not good doctors. It takes you 9 hours to get to a doctor who's in Los Angeles. So I can't tell you. Yeah. But there's really good doctors in Los Angeles. So thank you, everybody.